Well, good morning, everyone. I just wanted to start off by thanking the organizers of this meeting for the opportunity for us to be here. It's an honor to participate in this great society and be amongst our colleagues. It's also good to be back in person. You know, we did the meeting last year virtually, but it's good to see everyone's faces. Over the span of the next 20-30 minutes, I wanted to give an overview of diabetic retinopathy. I think all of us, in one way or other, are involved in care of diabetic patients. And over the last 10, 15, 20 years, there's been a significant improvement in our understanding of pathophysiology of diabetic retinopathy. And that's been really a springboard for a lot of great, exciting new treatment modalities that we have to help our patients with diabetes. So I just wanted to go over a few of the changes that occurred, review some of the findings. So the objective of my talk is to start off by epidemiology and risk factors of diabetic retinopathy. I'll briefly touch on current understanding of pathogenesis of diabetic retinopathy. I will review some clinical findings and classification of diabetic retinopathy. Then we'll follow up with some screening guidelines and follow-up guidelines based on the most recent preferred practice patterns. And then we'll touch on some management options that we have to offer our patients with diabetes. And along the way, I'll talk about some of the important pivotal clinical trials that some of those our practice has been involved with. I don't really have any financial disclosure to make pertaining to any of the topics that I'm going to be discussing in my talk. Now, we all know diabetes is a complex disease. It's, in essence, is a metabolic disease that results in vascular damage. And because of that, diabetes can affect any organ, if you really think about it. And again, we're all surrounded by diabetics. We all care for so many patients with diabetes, but it's very easy to get numb to the fact that diabetes has a huge impact on a patient's life, both at a individual level and also as to the society and healthcare system as a whole. Diabetes is the cause of half of the renal failures, patients that are ending up on dialysis and renal transplants. About 2/3 of patients with diabetes end up with some types of neuropathy, and that can by itself create significant morbidity for a lot of these patients. And a patient who has diabetes has 4 times higher risk of having a heart attack or a stroke. And in the US, diabetes is considered to be the 7th cause of death. Looking at it globally, 500 million people are diagnosed with diabetes. That's close to 8 to 9% of the whole global population. And every year, 5 million people die from diabetes, either directly or as an indirect cause. Globally, about 1/3 of the patients that have diabetes have some form of diabetic retinopathy. Not all of them lose vision, obviously. About 5% of those end up with significant visual disability, but just by the sheer number of how many people are diabetic, that's a lot of people that are losing vision to diabetes. And it is the primary cause of blindness in the folks that are still in the workforce, people that are in the age of 20 to 74. So even though that macular degeneration is the leading cause of blindness in the US, I think in terms of its impact on the individual and society, diabetes is a very important cause, because most of these folks with diabetes, they're still working and caring for their family. And so when they become disabled, it has a huge impact, not for their own, but for the society. Now, we all know hypertension is a big risk factor for diabetes. It's one of those things that we generally check every single visit when patients come into our clinics. We try to assess how they're doing with their blood pressure management. And this is a important risk factor that we have known about since the 90s. This study, a study that came out from UK called UKPDS, or United Kingdom Prospective Diabetes Study. It was a very neat study. It basically looked at a whole bunch of patients with type 2 diabetes, and some of these patients were medicated to keep their blood pressure under what they call a tighter control, as it was defined as blood pressures of less than 150 systolically and 85 diastolically. And this study showed that not only you can reduce risk of progression of diabetic retinopathy by having a better management of the blood pressure, but you can actually save vision. This study showed that by having a better blood pressure control, you can reduce risk of severe vision loss by 47%. That's significant. And that's something that I think we all need to care about when we see our patients with diabetes. And I sometimes feel like a broken, tape recorder. I'm always talking to them about how important it is to have a better blood pressure control. We all know glucose control and glycemic control is an important risk factor. How well a patient does with managing their blood sugars has a long-term effect on how well they do. Again, same study from UK back in the 90s looked at these type 2 diabetics, and some of them were controlled with diet, and some of them were put on medication. And folks that were put on medication, their A1Cs were kept less than 7, they did better. So association of diabetes, association of glucose control and progression of diabetic retinopathy is something that's well known. How about type 1 diabetics? A similar study, again, back in the 90s, this one came from the US. Again, this is one of those important epidemiological studies that we always reference back to, is the DCCT trial that looked at similar type of question, but looking at it in type 1 diabetics, and also same thing, patients that are type 1 diabetic with a better glycemic control, or those folks that had better A1Cs did better. What was interesting was in type 1 diabetics, where the study, when they looked at it, the first 2 years they didn't see much difference between the two. But after 2 years they noticed that they're diverging, that the patients that were doing better with their diabetes had a reduced risk of progression of diabetic retinopathy. Not only glycemic control is important, duration of diabetes is also important. So usually when I evaluate a patient with diabetes, a few things I care about. Number one, how long they've been diabetic. Number two, how well their diabetes is. I always ask about their A1Cs, and believe it or not, a lot of patients don't even know what their A1Cs are. Sometimes they ask them about how their diabetes is. So like, oh doc, my blood pressure was 120 today, it was great. That's almost a meaningless information for us, because they could have a good blood sugar that day, but we usually care about A1C because it's a measure of how their blood sugars have been over the last few months. Other risk factors that are important is obviously lipid control, how they're doing with their cholesterol management. As you know, diabetics are usually recommended to have to also be treated for their cholesterol. They usually have a lower threshold for treatment once they become diabetic. Pregnancy is a risk factor for diabetic retinopathy, and also nephropathy. Now, I briefly alluded to the fact that we know a lot more about pathophysiology of diabetic retinopathy, and I think it's been true across the board. And nowadays, we are understanding diseases at cellular and molecular level, and I think a lot of that we owe to our colleagues in oncology, because a lot of understanding of how a disease affects a patient and how a disease is formed at a molecular level and cellular level, and it's a springboard for creation of a lot of great therapeutic options that we have. So how does diabetes cause damage? So we understand that hyperglycemia causes damage to the blood vessel, and it does this by causing damage to the endothelial cells and pericyte cells. The pericyte cells are cells that are supporting cells. They basically have maintenance role on keeping the integrity of the blood vessels. We know inflammation plays an important role. We know that migration of white blood cells in the vasculature can play an important role in progression of diabetic retinopathy. And obviously the more important things is understanding that there are some growth factors that are either upregulated or downregulated, and this is the target for a lot of the treatment options that we have now. How does a patient lose vision to diabetic retinopathy? I like to think about this as sort of 3 different categories. Diabetic retinopathy can cause blood vessels to become leaky, and this abnormal permeability of the blood vessels causes leakage. And leakage causes tissue swelling, what we call diabetic macular edema. So diabetic macular edema in a diabetic patient is a very common cause of vision loss. Another important thing is vascular occlusion. As these blood vessels, the capillaries, as they're damaged with time, sometimes they just drop out and they occlude. So there is, a lot of times patients get into a phase where they just have ischemia, where the retinas are not well perfused. And as the disease progresses, you get into a stage of abnormal neovascularizations, and that's when there's recruitment of new blood vessels to form, and these blood vessels unfortunately form in the wrong location, and they usually have structural abnormality. And because of that, they can open a whole sequel of complications for patients, such as vitreous hemorrhage and tractional detachment and vascular glaucoma. This slide shows a list of very common findings we see in diabetic patients. We're familiar with these findings, but just for the sake of review and also talk about the classification of diabetic retinopathy, I'd like to go over very briefly about some of these findings. Retinal microaneurysms. These are the most common and usually initial findings in a patient who has diabetic retinopathy. And what they are, they're just saccular outpouching of the capillaries. And these capillaries, these microaneurysms can sometimes leak, causing tissue swelling, and sometimes they can thrombose. But they're commonly seen in patients as early manifestations of diabetic retinopathy. Intraretinal hemorrhages are common findings, and these are categorized as 2. We have dot blood hemorrhages and flame-shaped hemorrhages. And dot blood hemorrhages are different than flame-shaped hemorrhages because they can occur and they can be sourced from a different area. So these are typically hemorrhages that are coming from the venous side of the capillary, and they typically occur deeper in the retina. And that's why they have different shape than flame-shaped hemorrhages that are sourced from the superficial precapillary arterioles, and usually these hemorrhages can follow the track of the neurofiber layers at a more superficial layer of the retina, and they can form the shape of a spreading like a flame. Hard exudates are lipoprotein deposits that are usually associated with having macular edema. And the reason I say usually is because sometimes you see a patient that has hard exudates and you get an OCT, there's no swelling. So the reason is because that patient leaked at some point, and sometimes swellings can spontaneously resolve, but the hard exudates remain. And are typically seen at the edge of the area of retina that has edema and an area of retina that's still not developed edema. Can they cause vision loss? Yes. If these exudates are in the fovea, they can cause significant and sometimes permanent vision loss. As the disease progresses, we enter a realm of what we call a pre-proliferative diabetic retinopathy, and these are patients that have venous beading and IRMA, or intraretinal microvascular abnormality. As you can see in this picture, venous beading is these irregular dilation and constriction of retinal veins. And intraretinal microvascular abnormalities are usually seen when there's a shunting between an artery and a vein in the retina. And why they happen is because there is a segment that the capillaries are occluded, and there is a shunt formation between the arterial and the venous side. And sometimes when you look at these patients clinically, it's difficult to distinguish whether this is a neovascularization and the patient is already in a PDR phase, or is it NPDR. And the difference between IRMA and neovascularization is that IRMA usually does not leave the plane of retina. It usually stays in the retina. And sometimes if you have a question, we usually get an angiography, and IRMAs typically don't leak on angiography. So that's one way to distinguish between the two. But the main difference is that neovascularization, as we're going to talk about, it grows out of the plane of retina, versus intraretinal microvascular abnormality, as the name implies, stays within the retinal plane. Macular edema, again, a very common source of problem for diabetic patients, and that's when usually microaneurysms leak, and initially fluid starts accumulating between the inner nuclear layer and the outer plexiform layer, but as the disease progresses, edema can involve the whole layer of retina, and sometimes even it can cause subretinal fluid to form. So it's not unusual to have subretinal fluid in a patient who has diabetic macular edema if things are advanced. Macular ischemia is something that's hard to sometimes diagnose clinically. And oftentimes we get referred patients who are diabetic that are referred either by our optometry colleague or these are patients who have limitation in their best corrected visual acuity, even though they have seemingly normal OCT. Or you can have a patient who had uncomplicated cataract surgery, and they have limitation in how well their vision is. And it's something that's easily detected by either fluorescein angiography or OCTA, which is a newer technology. So in my opinion, if a patient has significant diabetic retinopathy, it may not be a bad idea to have a preoperative OCTA or fluorescein angiography, because a lot of times if we see foveal ischemia, we can sometimes set their expectations straight and have some informative prognostic information for a patient. And neovascularization is obviously when the disease is progressing, you have growth of abnormal vasculature that grows out of the retina. And the problem with this is that these neovascular membranes don't stay in the retina. They grow out of the plane of retina into the vitreous cortex. And left untreated, they can also turn into fibrovascular scar tissues, and these fibrovascular scar tissues can have contractile property, and they can pull on the retina and cause retinal detachment. And the end stage of diabetic retinopathy is someone who ends up with a tractional retinal detachment. And unfortunately, these patients have sometimes and often poor prognosis with their vision, and they are in need of surgery. Very briefly, classification of diabetic retinopathy. I like to leave diabetic macular edema separate, because diabetic macular edema can occur at any stage of diabetic retinopathy. A patient who has non-proliferative diabetic retinopathy can have macular edema. A patient with PDR can have macular edema too. So it's its own separate category now. And this used to be something that was a clinical diagnosis, but not anymore, because now diabetic macular edema in reality is an OCT diagnosis. And the term that we used to use is clinically significant macular edema is no longer used, because most of the studies that are being published, the definition of diabetic macular edema and the classification of diabetic macular edema is either center involving or non-center involving. NPDR is categorized as mild, moderate, or severe. I will talk about how that's categorized. And PDR, or proliferative diabetic retinopathy, is categorized as either early PDR or high-risk PDR. So what is mild NPDR? Mild NPDR is a patient who has just microaneurysms. When you look at them, yeah, they have microaneurysms, but that's basically it. But as the disease progresses, we have this 4-2-1 rule to classify patients that have severe NPDR. And 4-2-1 rule goes as this. So if someone has intraretinal hemorrhage in all 4 quadrants on your clinical exam, that patient is categorized or classified as having severe NPDR. And if you recall, we talked about venous bleeding and ERMA as pre-proliferative findings. So if you have those findings on your clinical exam, that patient is categorized as high risk or severe NPDR. So if someone has venous bleeding in 2 quadrants or ERMA in 1 quadrant, that's considered severe NPDR. So how do we screen patients with diabetes? Based on a preferred practice pattern, the screening of patients with diabetes really depends on whether they're type 1 or type 2 diabetes. And the reason for that is this. A type 2 diabetic patient is oftentimes asymptomatic. So a lot of these people, when they're diagnosed, you can bet that they were diabetic for much longer than that, and they just didn't know it. So a patient, when they're diagnosed with type 2 diabetes, are recommended to have a diabetic fundus exam right away. Whereas a type 1 diabetic patient is usually these are patients that become symptomatic and they're diagnosed right then, and recommended screening can be deferred by about 5 years. But for pregnant woman or pregnant person or whatever it's called nowadays, recommended screening is immediately after conception, the first trimester, and every 3 months after that. And the reason is because diabetic retinopathy can progress during pregnancy, so these patients need to be monitored. Now, what do you do with a patient who already has diabetic retinopathy, and how often do you monitor it? That also depends on the severity of their diabetic retinopathy. If someone has moderate NPDR with no diabetic macular edema, you can watch them every 6 months or so, but as their diabetic retinopathy progresses, then the frequency of follow-ups need to be increased. And diabetic macular edema is a separate thing. If a patient has a center involving diabetic macular edema, but for some reason they have good vision, they're not being treated, that patient needs to be watched every month, because diabetic macular edema can worsen quickly, and if that happens, and if their vision starts going down, that's a patient that you need to put on treatment. Now, do I follow this treatment follow-up guidelines? It's not one size fit all. So if I have a patient that has, very high A1C, significant systemic vasculopathy, already has got renal disease, I usually watch that patient more often. But if I've got someone who's got good control of their blood pressure, good control of their blood sugars, low A1Cs, yeah, you can defer the treatment. So a lot of it also has to do with how well you know their systemic risk factors. We're going to talk about the treatment of diabetic retinopathy, but you can't talk about diabetic retinopathy and not talk about this classic clinical trial that came in our field, and it really set the stage for the nomenclature and definition of a lot of things that we still use. The Early Treatment Diabetic Retinopathy Study, or EDTRS, is a classic clinical trial in our field, and just so I don't give you guys too much detail, I just wanted to highlight about what we learned about this important clinical trial. And remember, this study came out before we had all the pharmacotherapies that we have available. This is a study from more than 20 years ago. So this study showed us that if you have a patient with diabetic macular edema, and that patient is treated with focal macular laser, not only you can moderately improve your vision, you can also reduce risk of vision loss. So maculofocal laser for treatment of diabetic macular edema is one of the things that we learned from this study. This study also proved that patients with severe NPDR or early PDR, when treated with PRP, they have reduction in the risk of severe vision loss. And we also learned a few ancillary things that it's interesting, but it's, we don't really talk about it very much. One was the effect of aspirin. Aspirin doesn't really alter the course of diabetic retinopathy. It may be counterintuitive, but based on that study, aspirin use did not really change the course of progression of diabetic retinopathy. It did not have any effect on vision, neither it increased risk of hemorrhage in diabetic patients. But the effect of aspirin for systemic risk control is definitely there. So a lot of these diabetic patients that are on aspirin to reduce the risk of MI and strokes. So how do we treat patients that have NPDR? This is, let's say you have a patient with 20/30 vision, no diabetic macular edema, and moderate NPDR. What do we do with it? And to be honest with you, there's really not a clear treatment guideline for those patients yet. We talk to them about importance of systemic risk control, managing their blood pressure, managing their cholesterol. And even though we have anti-VEGF agents, both Lucentis and Eylea are FDA approved for treatment of NPDR, not every single retina specialist is treating patients with that. And part of the reason for that is this, that some of these patients, yes, you can put them on treatment and you can see the diabetic retinopathy regress, but that doesn't necessarily translate into improvement of vision. So what do we do with our patients? Do I use anti-VEGF for NPDR? Yes. In selected cases, I do. If I consider a patient to be high risk, NPDR, if they have poor glycemic control, overall considered high risk, I sometimes put them on a course of treatment with anti-VEGF until they get their systemic risk under better control. Treatment of proliferative diabetic retinopathy is a must, because if a patient that has PDR is not treated timely, that patient can have significant and permanent vision loss. So that's why the screening are very important, because once a patient has progressed to proliferative stages of diabetic retinopathy, that patient needs to be treated. And a common treatment is PRP and also use of anti-VEGF agents. We still use PRP. I think it's a great treatment option. It's effective. It has some advantages and some disadvantages. Advantages, as I mentioned, is that it generally gives a more permanent effect. So if I have a patient that I'm not completely sure about how well they're compliant with their follow-ups, that's a patient I like to treat with PRP, because I don't have to worry about that patient not showing up to my clinic and then 6 months later coming up with a tractional low attachment. It does have its disadvantages. You're basically burning off someone's peripheral retina, and if that treatment is done aggressively, they can have some peripheral vision loss, they have some night vision abnormality, and sometimes in advanced cases they can have pupillary abnormality and sometimes corneal surface abnormality. Anti-VEGF agents are commonly used. They're fantastic treatment options. They lead to a rapid regression of neovascular membranes. But the downside of them is that you have to keep doing it. And it's once you do the treatment, patients do fantastic. But once you stop the treatment, there's a high risk. Patients are high risk for progressing. There's also some concern that if a patient has already progressed to tractional attachment, use of anti-VEGF agents can usually worsen that condition. Diabetic macular edema is something that has gone through a lot of evolution over the last 10 years or so. Right now, the mainstay of treatment for management of diabetic macular edema is use of anti-VEGF agents. Common things that we use is Avastin, Lucentis, Eylea, and the new one is Vabysmo, and that just recently became FDA approved. And this particular medication targets two different growth factors, VEGF and also Ang2, which has been shown to have some role in vascular stability. And the name of the game, every company is trying to find a medication that lasts longer in the eye, so you can reduce the treatment burden for these patients. And one of the things with Vabysmo is that it could be treated less frequently as every 3 to 4 months. Our practice was one of the centers that involved in the clinical trial on Vabysmo before it became FDA approved. Anti-VEGFs they work great, but they have their own limitations. The results of anti-VEGFs are not as predictable as it is for patients that have macular degeneration. Some patients with diabetic macular edema, they respond really nicely to these treatments, and some patients don't. So, and we don't quite know why some patients respond so well and why some patients don't respond as well. As I mentioned, the treatment needs to be repeated. So for these folks, because they're still in the workforce, the visits and the treatment burden is a huge thing. Obviously, cost and some issues with systemic side effects. We use ocular steroids. It's very effective at reducing macular edema. They came with two big drawbacks. They can cause cataracts, and they can cause elevation in the intraocular pressure. We do have different formulations of steroids. There are two different implants that we have that have longer duration of action. And obviously, maculofocal laser is still used. I think it's still a great treatment option for a patient that has diabetic macular edema, where you can see exactly where the source of leakage is. It's a focal leakage, and generally those patients, once you treat them with laser, they do very well. So I'm going to end with, over the next 3 or 4 slides, about where we are now. We are 100 years from the year that first patient was treated with the exogenous source of insulin. That was in 1922. And look where we are now over the last 100 years. I sometimes even have a hard time just keeping up with all the drugs that are becoming available for treating patients that have diabetes. So where are we with vision? We can take a patient that otherwise would lose vision. We can improve their vision by about 3 lines and keep it with treatment. This is something we couldn't do before. And across the board, complications of diabetes has gone down significantly. MI, stroke, amputation, everything has gone down because patients are being better managed. How are these patients doing in terms of their life expectancy? 30 years ago, if you were diagnosed with diabetes, you had probably 30 years reduced life expectancy than in 2015. And you still have reduced life expectancy, but a lot less. And future is bright. I think future is going to be less laser, less surgery, less cutting, and it's going to be more of a molecular targeted treatment. There's a lot of drugs in the pipeline, and we're fortunate that our practice is involved in many of the studies and working with different pharmaceutical companies in bringing these treatment options to patients. But we've come a long way, but we still have way to go. So to summary, screening and follow-ups of diabetic retinopathy patients is more important than ever because we can now save their vision. The treatment is using some of the old standard treatments such as laser and augmenting that with the new treatment options, and our patients generally do very well. I wanted to thank you so much for giving the attention to this talk. I'll be happy to answer any questions maybe after Sean gives his talk. Thank you.